Thank you, Ketan, and really happy to be here today. So my talk is on an update on diabetic retinopathy. As you know, it's the most common microvascular complication in people with diabetes. So these are my acknowledgements and disclosures. So what I'll cover today is to update you on some of the screening methods and developments for diabetic retinopathy. I'll also then talk about some imaging innovations that have happened in this field, and therefore we are hoping for a new classification system for diabetic retinopathy. And then I will proceed on to treatment, that is anti-VEGF treatment for diabetic macular edema and what is in the horizon, and then go on to proliferative diabetic retinopathy. So, I mean, I don't need to tell this crowd that the diabetes pandemic or epidemic is just ongoing, and most of our people with diabetes are now concentrated in low and middle income countries where there is no primary care infrastructure. They have to spend out-of-pocket expenses for their healthcare, and therefore the diabetes-related global blindness is also quite concentrated in these areas. So there is a need to do something to screen these patients and treat them for sight-threatening diabetic retinopathy, because the diabetic retinopathy is asymptomatic till very late in the severity level. So we know that in the UK, we have an excellent diabetic retinopathy screening program. We have approximately 60 million population in UK, of which 5% of them adults have diabetes. We have good primary care infrastructure here. We have a good diabetes register, and therefore the diabetic screening is near 80% or 200% in most areas in England. However, this program is very expensive. It costs us 120 million a year, and probably the cost will only increase over time. And our screening protocols are very elaborate and with very good legal cover, etc. So on the whole, it's we are very proud to have such a good diabetic retinopathy screening program, but it has its difficulties as well, because we can't then replicate them to other parts of the world because of the cost pressures of the screening program. However, we know that from the UK especially, or many parts of Europe as well, that diabetic retinopathy screening and timely treatment does decrease the rate of blindness due to sight-threatening diabetic retinopathy. And we have started to see that already in the UK in the last 5 years or so. So we definitely know from evidence that we need to screen our patients for sight-threatening diabetic retinopathy. So we do need to find other ways of screening people with diabetic retinopathy especially in low middle income countries. For example, this is data from India, which says that there are 70 million people with diabetes and 77 million with pre-diabetes in India. 70 million is more than the whole population of UK population taken together. So we know that such stringent protocols cannot be replicated in such countries. However, WHO does insist that we screen for these complications and tailor it to the local needs and resources. So I just want to explain what the tailoring of these screening programs are in other countries. Ideally, we want a retinal camera that is portable, non-invasive, very reliable, and easy to use by relatively unskilled personnel. And it's so small that we can place it in all diabetes care centers, primary care, pharmacy, etc. That will allow a global coverage. We do have several such portable photograph for the cameras these days, but the retinal images are just as good as how well the unskilled persons can take the photograph through an undilated pupil. So that's the next challenge, actually. We have done several studies on looking at algorithms with within the smartphone cameras or handheld cameras, we can place AI algorithms on it so that they are automatically read as whether the patient needs to be referred or not. We have done such studies comparing different types of cameras versus our standard care, and they all seem to give very good results on retrospective data. However, our biggest challenge is how do we implement this in real life in a diabetic retinopathy screening program? We have got FDA approval for artificial intelligence algorithms in several places around the world, like IDXDR, IART, Google, Seri from Singapore, RedMarker DR from Portugal, etc., etc. So it's not the problem that we don't have a system, we have it, and all of these have been tried and tested in a retrospective population, and that's why the FDA has approved them. However, when it comes to implementation in a care pathway, we just have not got to grips as to where this AI system should sit in a diabetic retinopathy screening program. The ADA insists that we have to optimally utilize the AI system, but where should we do it to screen off all the no DR patients and allow the DR patients to be screened by humans? Or where exactly should we place the AI system is still a big challenge. Secondly, implementing this on a day-to-day practice needs further studies, and these are currently ongoing. So in the UK, we haven't, at least in England and Wales, we haven't yet introduced the AI into standard diabetic retinopathy screening programs. And the reason is because of the need for legal cover, privacy, data protection, etc., when using AI. So ideally, we also need an economic analysis to see how much we will save by having the AI in our camera system or outside of the camera system to grade all these images. It always sounds cheaper, but when we try and integrate it into the system, we might find that we are likely to find that the economic analysis may not really be that cost effective as is projected at present. The very big issue in low and middle income countries like India and China is that there is high cataract prevalence. So to use a handheld camera to go through a pupil that has a very poor media opacity due to cataract is still very challenging. One good thing that ADA has told us is when not to use AI. So it's not advisable to use it in patients with known retinopathy, when we have to make treatment decisions on sight-threatening diabetic retinopathy, and when patients have visual impairment, symptoms of vision impairment. So these clearly tell us that maybe AI should be used in patients with no diabetic retinopathy and already diagnosed as no diabetic retinopathy in a previous screen. That's about screening. I'll now move on to why we expect a new classification system on diabetic eye disease. We know from several basic science experiments that both the nerves in the retina as well as the vasculature are affected. So diabetic retinopathy is no longer a microvascular disease. It's also affecting the neuronal layers, exactly like how our previous speaker showed in confocal microscopy of the cornea. The nerve fiber reduces in the same way we have shown that there are neuronal changes in people with diabetes. And we now have a gadget called OCT angiography, where instead of just looking at microvasculature on a color photograph, we can also look into the deeper layers of the retina. And what we have found out from this sort of OCT angiography is that we are able to see early changes in the deep capillary plexus of the retina even before we see a microaneurysm on the retina. So that shows that there are several other changes before we see the first microaneurysm in the microvasculature. You can see this one example where when you compare healthy with different grades of retinopathy, look at the second column is diabetes without diabetic retinopathy. And in the bottom, you can see how distorted the foveolar vascular zone is in the deep layer, suggesting that these vascular changes do occur very early on. In fact, as what the previous speaker mentioned, these changes are even seen in pre-diabetes in some individuals, although rarer than what we saw in the previous presentation on peripheral neuropathy. We also know that the retina is really a complicated structure with neurons and microvasculature intertwined. So it's really not a microvascular abnormality only, it's the Muller cells and the neurons are also affected. So now we term this as a diabetic neuroretinopathy or diabetic neurovasculopathy. And therefore, when a new classification system comes out, we have to include this neuronal changes as well. So what we still don't know is what precedes the other. Does neuronal changes occur early and then cause microvascular changes, or is it vice versa? And we know that first 5 to 10 years of diabetes, all these structures are affected. So there are a lot more studies to be done to understand what comes first, but end of the day, both the structures need to be treated earlier on. This is why we need a new classification system. As you can see, when you have a new onset diabetes, you are relatively in good systemic health. The visual function is normal. The biochemical abnormalities are just just abnormal. And then quality of life is not affected. There is no nerve function problems in the retina or vascular functions. So that is the group A patients that you see on this chart. As you go on, when these parameters start worsening, there's a whole lot of group B patients. And then you have the last group of group C, where these patients are really sick. Their retinopathy is also very much worse. They have sight-threatening diabetic retinopathy, usually associated with poor systemic health and poor quality of life. So that is how we have to do the new classification. We have always been focusing only on C and some of B, but we now have to start from A downwards. And I think the other fields have far progressed, both cardiovascular and peripheral neuropathy. We are now taking a step backwards to start that sort of classification system. We also have the wide angle camera. As I said previously, smartphone takes this type of 55-degree images, concentrating on the disc and the macula. But now we have these wide field angiograms, as you see here, that show so much more retina that we have never seen before. And you will see that there are several retinal microvascular changes beyond the usual 7 fields that we see. So this is also an urgent need for us to classify and place them within the diabetic retinopathy classification system. So we expect that there are different types of retinopathy now just based on the location of these lesions on wide field. The peripheral lesions are called predominantly peripheral lesions. So patients with predominantly peripheral lesions are likely to have more disease progression than those with central lesions. However, a recent article just showed us that it actually varies with ethnicity, and people in South Asia have central lesions more than peripheral lesions. So even the ethnicity seems to, these lesion locations seems to be explained by ethnicity. Next, we come to treatment of diabetic macular edema. As most of you will know, we give a lot of injections to our patients, anti-VEGF injections. So the burden of patients having anti-VEGF treatment is really high. And in addition, they are non-responders to our current anti-VEGF agents. Therefore, we are now looking forward to new drugs in this area. And if you ask our physicians, this survey was conducted in Americans among the retinal specialists, and we found that the 2 most common identified reasons for burden are the need to give a lot of injections over a long period of time. So we need an agent or multiple agents that increase the durability of the effect of anti-VEGF agents so that these patients do not need to come in every 4 to 6 weeks for their injections. And that is the good news now. You can see how we started off with our first anti-VEGF agents in 2007. We are 15 years down the line, and in 2022, the previous anti-VEGF or the first anti-VEGF agents that we had have all become having biosimilars being done for them, while we have newer drugs that seems to prove to us that there is increased durability. The most recent recently available drug is faricimab or Vabysmo. This is the slide about Vabysmo. In 2 years, 62% of the patients could go into 4 monthly dosing, and 78% of the patients could go in for 3 monthly dosing. That seems to be a change in the way we can manage diabetic macular edema. We just got it approved last September, so we are all trying to learn how to use this drug. But I think this is the first of the many drugs that will come our way that show that we can actually provide durable agents for patients with diabetic macular edema. However, we have these biosimilars for the older drugs, but because they do not have that amount of durability, we believe that its usage will be limited unless we find that the durable agents are not actually as durable as the trials suggest. Coming to proliferative diabetic retinopathy, I'm afraid to say that laser is still the mainline treatment for proliferative diabetic retinopathy. I mean, this is despite the fact that we in the UK and other whole group called Protocol S in DRCR all proved that anti-VEGF is superior to laser treatment in proliferative diabetic retinopathy. We still can't use it because anti-VEGF agents have to be given very regularly. These patients are really sick patients when they have PDR, and also it's very costly. And if they don't turn up for the appointments, anti-VEGF therapy is short-lasting, is short-acting, and therefore these patients can actually end up with more complications if they are not seen in time. So that made us go into a more permanent laser therapy, but we are hoping with this more durable agents, we will be able to use anti-VEGF as well for these conditions, for this proliferative diabetic retinopathy. Our biggest problem is, to date, all these anti-VEGF agents seem to cause a cosmetic improvement to the diabetic retina, but it doesn't seem to be improving the non-perfusion, or the vessels lost seem not to regain, and even it can still progress. Non-perfusion can still progress despite being on anti-VEGF agents. So this is why we want to keep lasering the patients until we have an agent that can actually improve non-perfusion. That's where we are, but this area is still needs a lot more research on how to improve non-perfusion, and time will tell. So thank you very much. So in conclusion, I expect several advances in the field of diabetic retinopathy in the near future with new classification system, automatic grading, and durable drugs, hopefully with less cost pressure to the health system.
Thank you, Sobha. That was tour de force, a really swift trip around diabetic retinopathy. I'm going to ask you a slightly separate question from the presentation that you gave, if I may. One of the things that always concerns us as diabetes doctors and people looking after diabetes is, of course, early worsening. And one of the issues that, and I know you're involved with this, and I'm involved with this, was the FOCUS trial, for example, showing that the use of a subcutaneous GLP-1 was associated, surprisingly, with an increased risk of developing proliferative retinopathy. But there's also data from, I think it was Rafael Simo, actually, when you use topical GLP-1 in the eye, that actually prevented proliferative retinopathy. So can you try and explain why, in some respects, subcutaneously it worsened it, topically it may improve it or protect against it?
It's, I mean, no one knows the right answer for that, but I would say that with our newer agents, or even with insulin, as you know, when the control is much more brisk with that. The decline is very quick with all these systemic agents compared to topical therapy. And I think we don't see that worsening in topical therapy just because the effect is much lesser. That steep decline is not there. So I think that is why we are not seeing that worsening. But I should stress this early worsening. If you see these patients regularly and just do a photograph of these patients, there are very few of these who will actually go to proliferative diabetic retinopathy and vitreous hemorrhage. I think what happened in all these trials is, first of all, they had only a record of adverse events as retinopathy. They did not photograph the patients. I'm not saying it will not worsen, it will worsen, but we know from our DCCT, UKPDS, etc., that that's a transient measure. I don't think any of these drugs actually cause the worsening. It's all related to the sudden decline of HbA1c.
So you're saying topical doesn't really affect the systemic effect. It's just a topical effect as opposed to subcutaneous, which is systemic.
That's correct. Yeah.
Okay. Thank you so much. That was really very helpful. Hopefully the audience appreciated it certainly as much as I did, because I certainly learned a lot from you. Thank you so much, Sobha.